Hello everybody. Today we are going to discuss about the cardiac output monitoring. This was also a question which was asked in DRNB critical care exam in October 2023. So cardiac output can be measured in the number of ways from the simple clinical observation to the invasive hemodynamic monitor. Estimation of the cardiac output has an important role in the patient management during anesthesia and the critical care. This ranges from the monitoring of the predictable changes of the anesthetic induction to assessing cardiac output during anesthesia for major surgery or resuscitation of trauma victims and critically ill patients. Advanced monitoring techniques are often used when the clinical signs are difficult to interpret. Now about definition. Cardiac output is the volume of the blood ejected from each of the ventricle of the heart per minute and is therefore the product of the stroke volume and heart rate. The unit of the cardiac output is liter per minute. Cardiac index is the cardiac output of the patient, reference to their body surface area, and has a unit of liter per minute per meter square. Stroke volume is the volume of the blood ejected by each contraction of the ventricle and is determined by the preload and the contractility and the afterload. Preload describes the tension developed in the ventricle wall at the end diastole. The tension is difficult to measure and the end diastolic pressure is taken as a surrogate measurement. Contractility refers to the amount of the work the heart can generate at given level of the preload and afterload and is estimated by the maximum rate at which ventricle can generate a change of pressure over time. Inotropy is used to explain the increase in the work done by the heart and is independent of the heart rate, preload, and the afterload. Afterload is the tension that needs to be generated in the ventricle wall in order to eject the blood into the arterial system during systole. This is largely determined by the resistance of the arterial system, the systemic vascular resistance. And it is calculated by mean arterial pressure minus central venous pressure upon cardiac output into 8. The unit of the systemic vascular resistance are the dyne second per centimeter square. Cardiac output is determined by and therefore can be manipulated by alterations to the heart rate and the rhythm, preload and the contractility and the afterload. Cardiac output informs us of global blood flow and therefore oxygen delivery and does not describe the delivery of the oxygen to each organ whose function must be assessed individually. An appreciation of how information is measured and the derived using cardiac output monitor is essential in order to use information accurately and appropriately. Thorough assessment of the patient's clinical status strongly influence the interpretation of measurements made. For example, cardiogenic shock and the obstructive shock due to tamponade will give a low cardiac output but can be differentiated by the patient's clinical sign. There is wide variability between the practitioner in the measurement and the interpretation of cardiac output data. And using these various techniques, there are currently available. For this reason, the clear evidence that they benefit the patient outcome is difficult to obtain. Now about measuring cardiac output. The interpretation of the data from the invasive hemodynamic monitoring is made in the light of clinical examination. Heart rate, blood pressure, pulse strength at various sites, blood, patient color, respiratory rate, and core to the peripheral temperature gradient all give indication of patient's hemodynamic status. A patient's ability to compensate for a hemodynamic insult is highly variable depending on age, premorbid status, and other comorbid. An example is the rise in diastolic pressure in early hypovolemic shock associated with peripheral vasoconstriction that is usually only seen in young fit individuals. In addition, clinical parameters such as urine output, capillary refill time, and cognitive function give a guide to end organ perfusion. Measurement of lactate and the base deficit in the arterial blood, and in particular, the trend of these variable over time gives non-specific information about patient's organ perfusion. The organ saturation in the central venous blood is also gives a global indication of hemodynamic status and is useful in directing fluid therapy and is reliable surrogate of mixed venous oxygen saturation. Now about esophageal Doppler. The Doppler probe is inserted into distal esophagus and is directed to measure blood flow in the descending aorta at about 35 to 40 centimeter from the incisor. The monitor calculates the cardiac output using descending aorta diameter, which either obtained from the age-related monogram or measured directly. The ventricular ejection time corrected for heart rate gives the indication of preload, and the peak flow velocity estimates the contractility of the ventricle. New probe incorporating M-mode Doppler measurement may improve accuracy and reliability. Now, the practical application. The technique is straightforward, easily learned, and relatively non-invasive. The disposable probe are easy to insert. However, some expertise must gain in recognition of intracardiac and pulmonary artery signal. Continuous measurement is possible, although frequent positional adjustment are needed. Some user variability is inevitable. Advantage: the system is small, relatively portable, but requires an electrical power source. The calculated cardiac output correlate well with that of the pulmonary artery catheter. The cardiac output data is best used as the trend to guide effectiveness of intervention such as fluid challenges. Pediatric probes are available. Now, disadvantage: the few complications have been described, but esophageal injury is possible. Esophageal Doppler use is contraindicated in the presence of esophageal varices. When the patient is positioned on their side of for surgery, movement of the mediastinum with ventilation makes reliable probe position impossible. The probe is poorly tolerated in awake patient, although thinner nasal probes are available. Now, the transesophageal echocardiography. The specialized esophageal probe is inserted into esophagus, providing real-time, high-resolution of ultrasound images. Both qualitative and quantitative values of cardiac output are available. Using two-dimensional cross-sectional area measurement, the Doppler flow measurement at that point, and the heart rate. Now, about practical application, the multiplane transducer is inserted into esophagus stomach, where various standardized views are gained. Advantages are large amount of hemodynamic information is available beyond just cardiac output. Disadvantage: the probes are still expensive and machinery is large and bulky. Various levels of examination skill are required, and these take time and resources to learn. Full study can take over 20 minutes. Some form of local pharyngeal anesthesia and sedation is required to tolerate the probe. There is a risk of trauma from the probe, although the risks are low in patients with no esophageal disease. The probes generate a degree of heat and they are therefore not suited to continuous measurement. As technology advances and the cost decreases, the transesophageal echocardiography may find more application in theater and the ICU. Now, lithium dilution monitoring, LIDCO, and the PulseCo and the LIDCO Pulse. This technique combines the technique of lithium dilution and the pulse counter analysis. A small dose of lithium is injected into peripheral vein, and an ion selective electrode is attached to the peripheral arterial line. The area under the curve of plot of lithium concentration against the time allows the accurate calculation of cardiac output. The information is then used to calibrate the pulse score, which provides beat-to-beat cardiac output measurement using pulse counter analysis of arterial wave. About practical application, the convenience of this system is that it uses the catheter, which are likely to be already in place and are likely to be needed in critically ill patients. The system requires some familiarity to set up and is relatively quick. The total dose of lithium is small and is clinically significant. Calibration is recommended every 8 hours or after any significant change in the patient's clinical condition. Advantage: a figure for stroke volume variation is produced and provides indicator of volume responsiveness to fluid therapy. Now, disadvantage: system cannot be used for patient taking lithium and those who have recently received vecuronium and atrazine. The monitor performed poorly in the presence of atrial fibrillation and other tachyarrhythmias. The system is prone to technical difficulties related to damping and resonance within measurement system. Now, thermodilution pulse counter monitoring. The theory of technique. This technique uses arterial pulse counter analysis to measure cardiac output and correlate well with the PAFC. Stroke volume variation gives indication of the blood volume status of the patient. The system is calibrated using intermittent cold transpulmonary thermodilution, where cold fluid is injected through central venous catheter and traverse the pulmonary circulation. The curve of blood thermodilution is measured in systemic artery and in addition to cardiac output, and the other data is derived. Calculated extravascular lung water gives an indication of water content of the lung and is increased in the left ventricular failure, pneumonia, and sepsis. The normal range is 3 to 10 ml per kg, and values greater than 40 ml per kg are associated with increased mortality. The intrathoracic blood volume index gives an indication of blood volume status. Pico Plus replaces the original Pico machine in 2002 and have improved displayed automated feature and allow the use of room temperature injected for calibration. Now about practical application, the specialized arterial catheter inserted into either brachial artery and femoral artery is required along with either thoracic or femoral central line. Some centers uses the treatment algorithm based on this variable to guide use of fluid and inotrope in an attempt to maximize intravascular filling without increasing extravascular water and causing pulmonary edema. The use of extravascular lung water as an endpoint for resuscitation has not been validated. Now, advantage, the arterial line can be simultaneously used for blood pressure monitoring and for blood sampling. The system is relatively easy to set up and calibrate. Disadvantage, the arterial catheter is relatively large gauge and expensive, although few complications have been reported. Recalibration is required every 12 hours or following major changes in patient's clinical condition. Now, the pulmonary artery flotation catheter. Dye dilution is the gold standard for measurement of cardiac output, but is important for clinical practice. Thermodilution using pulmonary artery flotation catheter uses similar principle. However, the use of pulmonary artery flotation catheter have been hotly debated in recent years, and use in United Kingdom is currently low. The recent PSC MAN trial showed that no improvement in survival for patients randomized to have pulmonary artery flotation catheter inserted compared to those who were not. Now, theory of technique, flexible balloon tip flow directed catheter is inserted via wide bore catheter sited in the central vein. The catheter is floated through the right atrium and the ventricle to enter the pulmonary trunk. From this position, it can intermittently be wedged in one of the pulmonary arteries. The catheter allows the number of variables to be measured and others to be derived. The major variables are pulmonary artery pressure, pulmonary capillary wedge pressure, cardiac output, and mixed venous oxygen saturation. Traditionally, cardiac output is measured by thermodilution of 10 ml ice water injected through proximal lumen of the catheter and measurement of fall in the blood pressure against the time from the injection. As cool blood passes the distal end of catheter and allows the calculation of cardiac output of the right ventricle. Semi-continuous cardiac output measurement are now available, which use the warming coil in the right ventricle portion of the catheter. The sequence of heating and recording gives the average cardiac output after short delay. Now about practical application, the catheter is inserted with reference to the waveform C. The insertion may take several attempts and is difficult in patients with low cardiac output. Now, advantage measurement of cardiac output is probably the most reliable of variable measured using pulmonary artery flotation catheter and is therefore valuable guide to intervention introduced to increase cardiac output. The numerous assumptions made in the interpretation of pulmonary capillary wedge pressure as a measure of preload or ventricular filling make pulmonary capillary wedge pressure a less reliable measure. Some unit uses the mixed venous oxygen saturation measured using sample taken slowly from pulmonary artery aperture of the catheter as a further indicator of patient's overall tissue perfusion. Now about disadvantage, the invasive monitor is associated with number of potential complications. PSC man study recorded non-fatal complication in 10% of insertion. In addition to the usual complication of central venous access, pulmonary artery flotation catheter may cause arrhythmias, heart block, rupture of right heart, pulmonary artery, thromboembolism, pulmonary infection, valvular damage, and endocarditis. Partial CO2 rebreathing, FIC monitoring, or NICO. The NICO monitor uses the rearrangement of FIC equation from CO2 elimination. It is relatively non-invasive, although it can only be used for patients who are intubated. Practical application, a small disposable plastic loop is placed between the ventilator Y-piece and the patient. It contains rebreathing valve, a differential pressure pneumatograph, and mainstream infrared CO2 analyzer. Only one calibration is required for setup. A bedside computer induces episode of rebreathing every 3 minutes, each lasting for 50 seconds. This raises the end tidal CO2 by 0.4 to 0.6 kilopressure. By rearrangement of Fick principle for CO2 elimination, a value for the total pulmonary artery blood flow can be calculated. Assumptions are made about the shunt fraction and peak PaCO2 being equal to end tidal CO2. Advantage this include easy set. Various pulmonary volumes such as dead space are available. Disadvantage, although sold as non-invasive, it requires patient to be ventilated and preferably have access to the arterial blood measurements. Its main area of the use has been cardiac surgical patient and in relatively stable ICU patient. Thoracic bioimpedance. Theory of technique. The technique depends on change in the bioimpedance of thoracic cavity during systole. Practical application. A series of ECG type electrode are placed on thorax and neck. A small and non-painful current is passed and the measurement made. Advantage. Derived stroke volume is calculated and cardiac output measured. Thoracic fluid content is also measured, and this is the least invasive method of cardiac monitoring and was initially conceived for space flight monitoring. Disadvantage, it is not useful for significant aortic regurgitation and open chest procedure. The correlation with the pulmonary artery floating catheter in critically ill patient is inconsistent. Thank you guys.